All right, let's talk about venous thromboembolism real quick. So before we get into it, let's dust off patho real quick. When we talk about venous thrombus, we're talking about blood clots in the vascular system, so particularly in the venous system. I do want to just draw attention real quick to a couple of the key terms here. So we've got DVT, which is a deep vein thrombus. Thrombus meaning the blood clot is attached to the vessel wall, so it's stationary, it's in one place. And then there's a thromboembolus, which is a detached blood clot. So this one is traveling in the circulatory system, which is not awesome. Super bad situation there. Getting back to our DVTs, our deep vein thrombosis, recognizing cues in our assessment, we're looking at our skin, circulatory, and risk factors is a big one. Circulatory, a couple things we want to point out. We're not talking about actual blood flow problems. We're talking about like the results of blood flow problems, particularly with our thromboembolisms, our traveling blood clots. So we're going to be looking out for complications of VTE in our respiratory and neuro system, but about the circulation for our respiratory and our neuro. So talking about PE and stroke as our big complications of VTE, but more to come on those. Risk factors, patients who are at super high risk for VTE, who are probably going to be prescribed VTE prophylaxis. Patients who have wounds, such as surgery or other wounds like pressure injuries, things like that. Anytime there is naturally blood clot occurring as part of tissue healing, there's a high risk that other blood clots are going to be forming in the body. Arrhythmias, like cardiac arrhythmias, so abnormal heartbeats. Particularly, there's one arrhythmia that is at very high risk for blood clots, and that is atrial fibrillation. Because when the atria is fibrillating, it's not fully contracting, so there's blood that pools in the atria, and pooling blood, high risk for clotting blood. Sedentary lifestyle, people are more likely to have pooling blood if they're not up moving around because muscle contraction in the legs helps with venous return. So sedentary lifestyle, high risk for blood clots. And medications. There's some very common medications that patients use that can increase their risk for VTE, such as oral contraceptive use, in particular in conjunction with smoking. Very high risk with those two things together. So moving over to our analyzing of cues, so the specific symptoms we're looking for on the skin, we're looking for erythema, so redness, heat, looks angry, looks like there's an inflammatory response going on, and we can usually outline it. And we actually do want to outline it whenever we see erythema because we want to know whether it's spreading or not. It's really difficult to tell if erythema is spreading or changing shape. Just by kind of describing the erythema or even measuring it on a patient's body. The best way to tell if it's getting larger, smaller, is to actually take a marker and outline it right on the patient's skin with the date and time. That way the next day we can look at it and see if it's bigger, smaller, the same, and see what's going on there. Swelling. Patients are going to have unilateral swelling, and this isn't like edema swelling. This is like hard, inflamed swelling. So they're not going to be soft, like edematous material. It's going to be hard, almost like a bruise kind of swelling, like an injury kind of swelling. We do actually measure the calf circumference when we notice this unilateral swelling, so just on one side of the body, because we're going to measure that for how much erythema or how much swelling there is associated with that inflammatory response compared to the other. That'll help us with tracking healing of this injury, which we'll talk about in a bit. And pain. This is not a comfortable thing that patients go through. They will have pain. And they're going to have even more pain if you squeeze their calf. So please don't do that because a lot of bad things can happen. Moving on to some other cues that we're going to look for. So a D-dimer. This is a lab test. Our normal range is here on the slide, so less than 0.5 is normal. D-dimer is an enzyme that is present when patients are hypercoagulable, so meaning they're more likely to produce a blood clot. Reason patient might do that is if they've already got a blood clot. One clot leads to another clot, so on and so forth. So D-dimers aren't like proof of DVT, but there's a strong correlation with a positive D-dimer and a DVT. And then complications. We always want to be on the lookout for complications. Like we mentioned a couple times already, where a patient has one clot, they're very likely to have a second or a third or many more or traveling blood clots. So prioritizing hypotheses. On the medical side, screening is a big thing. We're looking for history of disease, especially like wounds or use of medications that can lead to an acute blood clot. Then we're looking for these symptoms, the physical exam symptoms, so that unilateral leg swelling, erythema, heat, that kind of thing, and a D-dimer. These are great screening tools to help us identify, is this patient like probably having a blood clot, or should we be chasing something else? And we skipped over one of these, a Hohmann sign. Hohmann sign is what's being pictured right here on the slide. So it's where you kind of support the back of the patient's calf. You take their foot from plantarflex to dorsiflex, and you do it kind of quickly, almost like a jerking movement. And if patients have a positive Hohmann sign, this is going to cause them severe pain. Pro tip, we don't do Hohmann signs on patients, especially if we really suspect they have a blood clot, because this can turn a thromboembolism or can turn an embolism into a thromboembolism, so a traveling blood clot. We can break it apart and send some of it somewhere else in the body, which is really bad. Don't do that. Imaging is also done on these patients. So we're going to have venous ultrasound imaging to actually look for the blood clot in the blood vessel, and they can see it on ultrasound. On the nursing side, we're worried about ineffective peripheral tissue perfusion, because if the blood clot is large enough, it's going to prevent venous return, can start to cause symptoms of edema, kind of pain, those kinds of things. And then acute pain from the actual blood clot. Blood clots aren't nice and smooth and round in the vasculature. They're really uncomfortable for patients to have in their venous system. So acute pain is a big thing we look out for. For risk management, risk for activity intolerance, because of the pain, because of the swelling, even the pressure from standing on that leg can be very painful for patients who have a DVT. And then risk for thromboembolism, so the detachment of that blood clot, especially if you're doing a Hohmann sign or poking it or other weird stuff that you shouldn't be doing. Basically, you just want to leave it alone and just, leave it alone. We're going to talk about management here next. So on the medical side, the solutions that we are looking at. If a patient has a blood clot, the very first thing we want to do is prevent it from getting worse. So the acute intervention that we're going to see is initiation of anticoagulation therapy. Fastest way we can make drug bioavailable for a patient is to give it IV. So that's where we're going to start with our IV heparin. This is going to be a weight-based dosing. So many milligrams per kilogram is going to be infused through IV infusion. We titrate that rate of infusion for heparin based on bleeding times. And we measure bleeding time, which is a fancy way of saying like how long does it take for a patient to form a blood clot, through two tests. One is a PTT, which is partial prothrombin time. Normal ranges are listed here. So 25 to 40 seconds is normal. For a person therapeutic on a heparin drip, we're looking for 45 to 70 seconds. So almost double our normal range. The other test you might start to see in some facilities is what in the nurse world we call an XA. It's not an XA, it's actually a 10, like Roman numeral 10A. And the 10A is for clotting factor 10A, because that's the specific place that heparin interrupts the clotting cascade, is at factor 10A. So we're actually measuring how much of that 10A clotting factor is available. So once patients are stable on a heparin drip, we want to start getting them onto something that's more sustainable, because continuous IV infusion is a pain in the butt to titrate every 6 hours. Patient has to get a blood draw every 6 hours to measure this thing. Then we're going to have to adjust it based on what their bleeding times are. Not a great long-term solution, but a great short-term, like acute initiation of therapy solution. So we may move patients onto a low molecular weight heparin injection, which is our next most rapid way to get drug into a patient. If we can't do IV, we can do sub-Q or IM. We can put it into the interstitial spaces so it can then be absorbed into the body. So we're going to do sub-Q enoxaparin or Lovenox. This is also a weight-based injection, but it's given once a day. It's like a subcutaneous injection that can be given once a day to patients. Patients will usually stay on Lovenox while we do what's called a bridge, which is where we're bridging their therapy from IV anticoagulation to oral anticoagulation, because we cannot send patients home with IV heparin drips. Not a reasonable solution. So we're going to transition them to an oral anticoagulant. So that can either be Coumadin or Xarelto or a couple of really popular ones that we use. Coumadin is a bummer for a few reasons. One, it has food allergies to everything you would consider food. So there's a lot of diet restrictions that patients need to go through if they're going to be compliant on heparin therapy or on Coumadin therapy, which is a bummer. So that's one reason it's terrible. The second reason is it takes about 5 days for a patient to become therapeutic with oral anticoagulation starting Coumadin. So they're going to be on a bridge for several days while their Coumadin level slowly kind of creeps up. And to measure whether a patient is therapeutic on Coumadin, we're going to check an INR lab. And those just the 3 letters, INR, stands for International Normalization Ratio. And for people who are like normal range is 1 to 2. Therapeutic on Coumadin is 2 to 3. Super therapeutic is greater than 3. So we're looking for that 2 to 3 range typically for patients on Coumadin. Another one is Xarelto or rivaroxaban, Xarelto. This one is great in that it works quicker, so patients can become therapeutic quickly. There's not a lot of dose titration, so that's great. The bummer is that there is an antidote available now, but it is very, very rare. For the last 5 years, we've been using Xarelto with no antidote available, which is a little frightening when we're talking about creating bleeding in patients. Basically, if they start bleeding, nothing you could do about it, which was not super reassuring in the healthcare world. But now we do have a antidote available. Unfortunately, it's not widely available, so still a bit of bleeding risk with Xarelto. All of these drugs that we've talked about are anticoagulants, meaning they are going to prevent a blood clot from forming. That means that we're not actually treating the blood clot the patient already has. Our goal of therapy is just to prevent it from getting worse. We are going to do that so that the body can naturally break down that blood clot. Because if we artificially do it, there's a risk of fragments breaking off and creating thromboemboli, or creating bleeding somewhere else in the body. So we found that it's best to let the body take care of the problem, and we're just going to make the best conditions possible for that to happen. And we do that through anticoagulation. And then on the medical side, anytime they're treating a patient with a blood clot, physicians get very, very worried about the complications of blood clots. So that being more blood clots. So particularly pulmonary embolisms and strokes, occlusive strokes. On the nursing side, we worry about impaired tissue perfusion because that clot is already blocking part of the circulatory system. We worry about that blood getting to distal tissues and preventing dislodgement. So we really worry about these things coming loose. And if they do come loose, they're going to cause a lot more impaired tissue perfusion. So some of the ways that we kind of prevent these things from dislodging and becoming thromboemboli is we want to counsel patients, don't wear tight clothing. And we're not talking don't wrap yourself up in something really tight like a crazy person. It means things like just tight fitting clothes, socks that are really too small or cutting into the patient's skin, especially over an area where there's swelling from a blood clot. No vigorous exercise. It's time to back off the training program right now because this is not the best time to increase your heart rate, your blood pressure with vigorous exercise, dislodging it. Don't massage the leg. Sounds obvious, but when things hurt, people tend to rub them. And we want to counsel patients, do not do that. There's a very high risk of clot dislodgement if we massage that area, so don't do it. And also don't cross their legs. Problem with crossing your legs is kind of like if you do it too long, one leg starts to fall asleep. We're actually impairing circulation to that extremity. And we don't want to do that because, again, the risk of dislodgement. Risk for bleeding. This is particularly because of the anticoagulation therapy that the physicians are going to be doing. So we want to make sure we're titrating that therapy appropriately and making sure we don't overdose our patients. Because if we overdose on the anticoagulants, our patients are going to bleed. So the first place we want to look for patients to bleed is on the wet parts of their body, right? Mucous membranes are going to bleed first. So oral mucosa, urine, stool, nosebleeds, in severe cases like the conjunctiva in their eyes can start bleeding, but that's super creepy and rare. You're going to see it in the mouth and the nose and urine first. So look for mucous membranes because they're going to bleed first. We also want to prevent patients from causing injury to mucous membranes because if they start bleeding, like they're going to keep on bleeding and you can get pretty severe pretty quickly. So we want to prevent patients from sticking things in their mouth, like sharp things like a toothpick, the back end of a pen, any other stuff like that. And we also want to make sure they're only using soft bristle toothbrushes because the harder bristles or medium bristles can actually damage the gums, and then we've damaged mucous membranes on a patient who has a high bleeding risk and bleeding and gross. Yeah. And then risk for injury, because if these patients bump into furniture and they can't form a blood clot, they're going to have these massive hematomas with very minor injuries. So we want to watch out for that. Also wearing footwear, like I have these patients wear their full shoes in the hospital because I don't want them accidentally kicking something and injuring their feet and getting a big wound from a very minor injury because of that anticoagulation. So the serious complications, we've talked about these a little bit by name. So pulmonary embolism, this is where part of that blood clot has broken off in the venous system, traveled back through the vena cava, through the right side of the heart into the pulmonary arteries and gotten stuck in the pulmonary capillary beds and is now depriving the lung of circulation so that gas exchange cannot happen in that area. Patients with PE, they tend to complain of chest pain, acute onset, stabbing, sharp chest pain, right in the middle of their chest. Very different than heart attack, which is more of a dull crushing type pain. This is like sharp, I've been stabbed in the chest kind of pain. Shortness of breath, absolutely a thing. And hypoxia because they have decreased surface area in their lung for gas exchange because the blood clot is blocking some of those capillaries from receiving blood supply. Interventions, anytime patient is short of breath, we want to put them in a position where they can breathe easier. That means sit them up, put them in that rescue posture. So high Fowler's is a great way to do that. Head of bed, HOB, up. And call for help. This is a bad thing that has happened, and we want to make sure we are reporting that to our interdisciplinary team and calling our friends for help because this patient is going to probably need to go to the ICU for this problem. If the patient then has a pulmonary embolism, they're at very high risk for a CVA because if part of that clot in their lung breaks off, then it's going to the left side of the heart, and those three little branches that come off the aorta, they go to the brain. So acute symptoms for a CVA, we're looking out for things like unilateral musculoskeletal deficit or facial deficit. So that half their face is going to be paralyzed. One of their arms is going to be significantly weaker than the other, or they may not be able to move or feel half of their body. Altered mental status. This can come in a couple different flavors. One is actual mentation. So alert and oriented status is going to go down. Patients can be less oriented, or it can be general neurologic status, meaning they're going to be more sedate. So it's almost like their Glasgow Coma Scale type rating is going to go down because they're not going to be as cognitively intact. Also hypertension. One of the body's natural responses to a blood clot in the brain is try to increase the pressure and get perfusion to the brain. So there could be acutely and emergently hypertensive immediately after an inclusive stroke. So we want to watch out for that. Interventions, first do a neuro exam because we want to be able to describe what we're seeing, that face, the arms, speech, mentation, things like that. So altered mental status, and then call for help immediately because these patients are very sick and there is a time window on treating these strokes. Here's your picture for a pulmonary embolism, kind of showing all the stuff, and your patients look like just as big a hot mess as this cartoon is. Truth. So the actions we're going to be taking as nurses. First, prevent physical harm in our patients. So we need to make sure that their environment is safe and that they remain safe. Watch out for furniture they can hurt themselves with. Make sure they're protected. People interact with the world typically, most often, with their feet. So make sure their feet are protected. Prevent physiologic harm. So this is like making the blood clot worse. So no tight clothing, no vigorous exercise. ADLs, totally fine. They should be getting up to a chair to eat, to go to the toilet for ADL needs, brushing their teeth at the sink, all that they should be doing. But this is, again, not the time to start like putting in some flights of stairs at the end of the hall, or like setting a personal best for walking laps around the nursing unit, things like that. Do not massage it because we don't want to create a thromboembolism, which can lead to more blood clots in different parts of the body, which is bad, right? Like I said, no PEs, no strokes, that kind of thing. And then we want to make sure that therapy is successful by monitoring for or assessing for complications of therapy, so overdose of therapy, particularly bleeding. So pay attention to the wet parts of the body, make sure that blood isn't coming out of them, and protect the wet parts of the body. So these patients, we need to look out for bleeding of the gums, nosebleeds, blood in the urine, stool, bruising, significant bruising, especially bruising that isn't associated with like an injury, like hitting something. We also don't want these patients like shaving with a straight razor or a regular shaving razor. They want to use an electric razor just to prevent like nicks on the skin, which can bleed a lot. Basically, we just want to prevent patients from being clumsy, and especially clumsy with sharp objects. That's kind of what the theme is here. On the medical side, we know that anticoagulation therapy is going to be going on. Heparin is a high-risk medication, so there is like a lot of double checks that we do with other nurses to ensure we're giving the right drug at the right dose to the right patient, like verifying our 5 rights, because there is high risk associated with it. And then advocacy. We are the ones at the bedside doing those assessments for complications like PE, stroke. So advocate if your patient starts to develop those symptoms, call for help quickly if you suspect that your patient has had a stroke or had a PE as a result of a DVT. Down here in the bottom is an example of how we titrate heparin drips, just so you guys have seen one. We're going to check their blood level, so you can see a PTT level or a 10A level. Both are listed there. And based on how therapeutic or subtherapeutic a patient is, will either increase or decrease the amount of heparin that they're getting. So for evaluation, the main things we want to be assessing to know that we've done a good job for our patients: no further harm. So stable embolism, no PEs, no strokes, things like that. We also want to reduce the modifiable risk factors. So if they've had a stroke or if they've had a blood clot, they're at high risk for having another. So we want to really try to reduce their modifiable risk factors if possible. Interventions in place for predictable risk. So this is talking about patients who we know are in a high risk category through no fault of their own. People who have surgery, people with wounds. That's why we give VTE prophylaxis to a lot of patients in the hospital, especially post-operative patients. Medical patients in the hospital get VTE prophylaxis because they're so sedentary. If they just get up out of bed and start walking around, then we don't have to stab them in the belly. Good motivator for your patients. Next evaluation thing is stable anticoagulation therapy. We know they're going to bridge from IV to sub-Q to PO. So we want to make sure that we are walking patients through that bridge, advocating for making that transition happen as quickly as possible for our patients. Because they're going to continue anticoagulation therapy into the outpatient setting, which may require routine blood draws, coagulation studies like an INR for Coumadin. So we want to make sure they're aware of that and that they have a place that they're going to go day of discharge for those blood draws. So a clinic has been identified where they're going to have their blood drawn. So what just happened? The key things with DVT: assessment. Early identification of DVT is so important because if we identify early, we can prevent complications from occurring by starting our effective therapy, by starting anticoagulation therapy. Early intervention is so important to prevent complications for DVT. Unilateral symptom presentation is like the big bad thing that could happen to patients. So we always want to keep an eye out for patients having signs and symptoms of stroke, because that is the kind of worst outcome that people can have from a clotting disorder. And then interventions, we've got medical interventions, which are really going to be about the prevention of that blood clot getting worse because the body's going to take care of the clot itself. And on the nursing side, we need to make sure our patients stay safe in that environment. So none of those complications, no clot spreading, no thromboemboli because of bad behavior like massage or tight clothing or vigorous exercise, things like that, or any of those risk factors are going to place patients at high risk for developing a blood clot. And then making sure they're safe on medical therapy. So anticoagulation therapy is at appropriate dosage, not causing bleeding. That's all we got for DVTs.